There we go. So we're now recording the meeting. So without much more ado, I'm going to now hand over to Alison to take you through the start of the event. So over to you, Alison.
Thank you, Ruth, and good evening, everybody. And I think the first thing I just want to say is thank you very much for joining this evening, especially when it's such a busy time and such a stressful time for you all as well. So we really appreciate your support in joining the meeting this evening, and hopefully you will find it a benefit. So we're obviously here to talk about the community pharmacies consultation service this evening. We are going to talk about the whole service, i.e. from any referral pathway, but we are going to focus predominantly on the GP CPCS because that's the newest part of the service. But our aims for the event are to highlight the priority that NHS England is giving to this service, talk to you a little bit about some myths, give you some handy tips and hints on good clinical handback and how you can maximise fees, talk to you about the importance of data, a little bit about staff training and revalidation, and then finally we'll be reminding you about the provider pay that's coming very shortly. So I think it's fair to say that NHS England is seeing this as one of its priority services for community pharmacy at the moment. So if you weren't aware, NHS England published its latest operational planning guidance on Christmas Eve, and in there it has this a quote that I've put in bold there, that it wants every opportunity to secure universal participation in the community pharmacy consultation service should be taken. So that shows you that the priority that that NHS England are placing on this service at the moment. And as you all know, PCNs have been encouraged to develop an implementation plan from the GP end as part of some of their incentives as well, and they've been encouraged to make at least 34 referrals per GP practice per 1,000 patients in the new financial year when that starts on the 1st of April. If you haven't seen it, in the last couple of days, NHS England have also added 3 new minor illness conditions, so referral from 111 to the list, which starts pretty much straight away, I believe, and they are scratches and grazes, teething and sinusitis. So again, the fact that they're adding new conditions all the time just shows you the priority that they're placing on the service. We wanted to give you some tips here as well about how frequently to check farm outcomes. The service spec does require you as contractors to check at what it describes as regular intervals throughout the day. We would recommend as a minimum first thing in the morning once you get ready to open the doors, mid-morning, lunchtime, mid-afternoon, and before you close to the public in the evening as well. And if you can get into that as good practice, because you will then also start to see referrals from 111, and also if you get any DMS referrals will also come that way as well. So you will start to see those things on a regular basis. So a little bit about myth busting. CPCS is not a suite of services, it's one service. So if your pharmacy is signed up to deliver the service, then you must accept referrals from all routes, not just the 111 routes. We've had some anecdotal reports from GP practices who have tried to talk to a range of community pharmacies about sending referrals for the GP element, and they've said that some pharmacies have said that they're not ready to deliver the GP CPCS element or even willing to deliver it. So key message, it's one service. If you signed up, you must accept referrals from all routes that are part of the service spec. Obviously, collaboration is key when implementing the service, especially the GP elements, and we want to try and encourage the continuation of strong relationships with the relevant GP practices that you link in with. We understand it's a very busy time at the moment, and the increased numbers of referrals might be putting additional pressure on your teams. However, this service is fundamental to making sure that the whole system is able to cope with the additional pressures that COVID and winter is bringing upon us. And just a reminder that there was an engagement fee that you were all paid a few months ago in terms of implementing the GP element as well. The little link there, we're going to talk about in a little bit more detail as we go through, as we are also going to talk about triaging versus drop referrals, so I won't cover that here at the moment. So just to refresh your memories on a bit of background, the 111 element of CPCS was launched in October 2019. It's now well established, and referrals are coming through for both urgent medicines, supply and minor illness. And you can see there that that's the data as it's been tracked over that course of time. So as you might expect, peaks and troughs corresponding with things like pandemics, bank holidays, etc., etc. But a general trend is going in the right direction. And then this highlights the direction of travel for minor illness, which is only started in October 2020. November 2020, and as you can see, that's on a good upwards trajectory within West Yorkshire. So I'll hand over to Ruth now, who will talk to you about the patient pathway.
Thanks, Alison. Can I have the next slide, please? So yeah, the GP referral pathway. So we're going to concentrate on, for this slide, the GP referral pathway, because the 111 route is probably quite familiar to you. So the first part of the pathway is the patient contacts the GP practice. And, you know, that will generally be by phone. We know that's the case for most of our GPs at the moment. The GP practice then triages a patient. Now we need to remember this isn't clinical triage. This will be triaged by a receptionist who hasn't got any medical or clinical training. They may well use an online triage service or their own clinical system to help them triage the patient. The idea being that what they do is they can direct the person to the best service. So then the CPCS is part of that triage when they set it up, so that hopefully they pull out most patients that aren't going to be able to be assessed by pharmacies and offer them an appointment or give them relevant signposting advice. But then that pulls out the CPCS referrals. Those practices have actually got an online tool that helps them refer into community pharmacy called PharmRefer, and that actually also has a triage too. Once the identified person is eligible for CPCS, they have to get consent from that person to make that referral, and then the practice sends a referral to the pharmacy. Now that's done, it can be done by several ways. NHS mail can be used, and indeed some practices we understand are using NHS mail, but we are strongly encouraging all our practices in West Yorkshire to use PharmRefer, or if they have EMIS, the EMIS integrated system. Both of those essentially mean for you get a farm outcomes referral, which we're all quite familiar with because we get this currently from 111. So that is how you should then get your referral into the community pharmacy, and that message is sent electronically, which, as Alison says, why it's really important to check your referrals. And then we move on to the consultation, which I'll cover in a little moment. Next slide, please. Now, one of the differences with the GP element of the service rather than the 111 element is there is some local protocols. So with 111, it's very much cast in stone around the director of services and which patients get sent through and how that happens and how you refer back. With the GP element, they've left some things to local protocols. So it's just important to note that, really. As I say, the referral method, can be chosen, and by the practice, it may not be farm outcomes, it could be NHS mail. They also will talk to the local pharmacies and agree a time frame for responding to email. Bear in mind that you might not be part of all those conversations, given that there's multiple pharmacies and multiple GPs. It might be that if you aren't a pharmacy that deals with many prescriptions, that protocol may have been decided and may be slightly different to what you have in agreement. So just something to point out as a top tip. The messages shared with patients are also agreed, and also the process, really importantly for referring back, which we know equates to about 1 in 10 patients need to be referred back to the practice because they need to have further assessment from the practice that we can't do in the community pharmacy. Really important that we get that process right, because what we don't want to happen is you join at the end of a very long queue of patients who are calling the practice. So that should be something which is agreed with the GP when they go live. Next slide, please. So I think one of the key differences to point out for the difference between the GP and the 111 element of the service is the referrals. So when a patient goes through the 111 route, whether that be 111 online or through phoning 111, the onus is on the patient to contact the pharmacy, and that's because referrals may be made when the pharmacy is closed, because you maybe have a 24 or even a 48-hour disposition, which means they don't really need to be seen for 48 hours. So the patient is told when the pharmacy is going to be open and asked to contact the pharmacy, and the pharmacy does need to make a check, and if you haven't had contact with the patient within 12 hours, you should then contact the patient. With the GP element, it is dependent on what's agreed, but we would strongly recommend that the pharmacy does contact that patient, so that you should be checking your referrals and you should be contacting the patient, because then you can determine whether you want to have a phone consultation, and if you do things appropriate, you can then ask the patient to come down at a time where you know you're going to be able to manage them and see them. So that is one of the key differences between the two referral mechanisms in. The suggested guidance is that it's 3 hours, so that the patient's given the message when they contact the practice, the pharmacy will contact you within 3 hours. As I say, it can be different, but we are trying to get some consistency so that it's not, we don't have too many variations on the theme. So we are asking for that 3 hours as part of that. And that's because we need to give patients a good quality service and ensure they receive a similar service to which they would have done if they'd seen the GP. So it seems quite a reasonable time frame. Also, I said the reason why I think it's important that the onus remains with the pharmacy to contact the patient is that I think it's better for safety netting. As I say, it enables you to decide whether you want to have a telephone consultation with them or not. So really key. And the success of the service does rely on robust and timely patient to pharmacy GP practice communication. So, that is really important, which is why we're really, in the conversations we're having with GPs that are going live, that is a real key point. How are you going to make yourselves available to the pharmacy should they need to communicate with you? And that should go both ways. So if you do happen to have a second phone line, which is a bit quieter and is answered more quickly, it might be good to share that with the GP practice. Next slide, please, Alison. So the pharmacy consultation process, this actually goes for either the 111 referral route in or the GP referral route in. So the pharmacy will contact the patient if it's from 111, or hopefully you will have contacted them. And then you can consult with the patient and you can decide how you want to do that consultation, whether that be, say, face-to-face or over the telephone. And if you have it, it can be by video consultation as well. Do make sure you undertake that clinical assessment, and it has to be the pharmacist. Check the summary care record if you need to, and also check your clinical knowledge summaries for any red flags to make sure there's nothing that you need to refer back. Patient information leaflets should be supplied if required, and you can get those from patient.co.uk, or indeed you can signpost people to the NHS website, which is very good. What is very important is that safety netting statement. If your symptoms do not improve or become worse, then either come back to see me or seek advice from your GP. You can call NHS 111 or 999 if the matter is urgent and a pharmacist or GP is not available. That is so important to give that safety netting, because that means that you have then transferred in some ways that responsibility back to the patient as to what to do. We do know that as I say, some consultations end in referral back to the GP or the 111 service, but I think we've covered that in other slides. So I think that's it from me, Alison. Back over to you for the next section, please.
Thank you. So I'm going to talk to you a little bit about data now. So these first couple of slides are about local data. So you can see on the left of this first slide here, it shows you that the vast majority of GP referrals for consultation are currently taking place on the telephone, which is perfectly appropriate. And the slightly larger pie chart on the right there shows you the outcomes locally from GP CPCS referrals. And you can see that the biggest share there is I can't actually see what it says on the screen, but anyway, you can see that there's one that's bigger than others. We will share these slides afterwards so that you can look at them properly. So this shows you, this is also local information. So this shows you once the consultation's finished and the claim's gone in with all the relevant details. These are the top symptom groups to date that are being seen through the GP CPCS. You'll note that the one that's got the biggest bar says other reason. That might be appropriate because there isn't a tick box, but if there is something that you can tick, we would encourage you to do so, because the data is being scrutinised on a regular basis, both locally and nationally. So to have real clear data about the actual symptom rather than just classifying it as other is really important if you can. And then the final data slide, this is actually national data. So what that group of graphs there is showing you. So you may have seen that somebody in NHS England published a blog last week, and this slide was within there, and this shows you that if you work in a supermarket pharmacy, you are more likely to complete your CPCS referrals than if you work in any other setting, which I thought was a really interesting finding. So that's just to sort of really concentrate the mind on the importance of data and to show you the level of scrutiny that the NHS England is placing upon all the data that's coming their way. And they have said that when we move to provider pay and you can capture your data via the API, that they'll be able to see even more granular data than they can already. So we expect these reports to become even more clear than they are at the moment. So back to you, Ruth, for talking about reflection.
Thanks, Alison. And my first reflection seeing those slides about the data is actually how much scrutiny is on that data and actually the level they're looking at. And we know they're looking at per pharmacy level too. So I think that's quite interesting to see because we don't always get that data back to see, but I think it's helpful to see. So next slide, please, Alison. So some of the kind of points that we've come across and some of the reflections I think we've had as a team that we thought might be helpful to share with you. We know that 1 in 10 patients needs to be escalated, and I think people often see that as a negative, but we want to flip that round because we see that as actually as positive because it means 9 out of 10 patients don't need to be seen by anybody else other than you in the pharmacy. Escalation doesn't mean that it was a bad referral in the first place. We need to kind of reframe that CPCS isn't about treating patients. Actually, CPCS is about triaging people. So it's, if we think that you're being asked to triage and check, can you manage this person or not, rather than you can't. I think that really helps when we do get somebody sent to us. So for example, if it's from 111 because they've got a controlled drug request, which we can't manage, that's appropriate we get that because that non-clinical call handler has no idea what a controlled drug is, or if they do, they don't know what schedule they are and whether you've got any leniency in supplying that or not. So yeah, it's just, I think, reframing sometimes that actually the service is not just about treatment, really it's about triage, and that's really important. We know there's going to be some referrals that you cannot treat, so you're not expected to treat everybody. And if they fall into kind of 3 categories really for me. There's ones where you very quickly can tell you can treat it. You can see quite quickly that it can be treated by community pharmacy. There's some also that quite quickly you can determine that you definitely need to be escalated up, and that's part of the service that you escalate either back to the GP practice or to the local care director, the 111 helpline. And there are some that sit more in the middle of the road, and they might need a little bit more management, advice and safety netting to know what to do with. So you are going to get the more complicated ones that unfortunately take a bit longer. But that is, I say that is part of being that triage. And unfortunately, not people don't always simply fall into I can sort it, no I can't box. So that I think the key message from that is it's about triage, and escalation doesn't mean it's been a bad referral. Next slide, please, Alison. So some other key points of things that we've come across. So engagement with the GP practices is really key. As Alison outlined, we have had some feedback that when practices contact pharmacists say, oh, well, no, we're not doing that, when actually the pharmacy is signed up. So be proactive about it. Contact your surgeries in your area and just let me know. I'm ready to have the CPCS referrals when you're ready to make them. Just let me know, give me the details of how you're going to make the referrals and how to refer back in, but we're ready and waiting for you. I think that will really help give them the confidence that community pharmacy is ready to do the service. Obviously, make sure you've got your local protocols and you've got your SOP includes them, so that if you do have somebody who doesn't work in the pharmacy very regularly, they can quite easily find those contact details should they need to make a referral back. Alison's already outlined how important it is to make regular checks. Both the farm outcomes, don't forget you need to check NHS Mail too, because for both the GP and the 111 referral routes in, it's their backup. And we have seen the 111 very occasionally flick across to NHS Mail. So do make sure that that's a regular thing you do in the pharmacy. And, you know, action your referrals promptly. We want to give patients confidence in the service. So really important we do take those actions. And a bit to reiterate what I said the last slide, you know, we're not going to solve every problem, but it's about knowing when to escalate. Next slide, please, Alison. This is talking about the escalation processes. We also get given those for 111 and for local care direct, but with your GP practice, you're going to have to discuss that with them. Another key point is around this service is it has to be provided for all the pharmacies opening hours. That's part of the service specification that, you know, so locums need to be aware and need to be able to provide the service. So you might want to reiterate with them. But as a reflection, we know over 94% of our pharmacies provide CPCS. So you asking your locum to confirm that they can provide the CPCS service isn't you asking for something that's difficult. And actually most other pharmacists will be asking them the same. So yeah, do bear that in mind. If there is an extenuating circumstance where you can't apply the service, do make sure you inform your local GP practices if it's in the daytime, and also make sure you do amend DOS so you don't get any more 111 referrals through to you that you can't manage. It's really important that we provide a really good service that helps build the confidence of those using it, both 111, but I think really essentially for local relationships, GP practices, because we want them to send the referrals. This is about bringing income into your pharmacy. This is about, you know, you getting, money from that global sum for you to help you remain viable. We need to make sure that patients accept the referrals, and we want people's experience to be positive, that when they talk, I was referred to the pharmacy and it was actually quite good because I didn't have to wait in that waiting room and they saw me quite quickly, for example. And also how it's managing that clinical risk. So when that transfer is made to you, either from 111 or the GP practice, you are you are clinically responsible for that individual patient. So you need to manage them appropriately and make sure that they get the care they need. So it's about building trust for me and confidence in that service. So there's some of the key learnings we've got. Next slide, please, Alison. Now, Alison mentioned earlier about dropped or closed referrals, and I think this is a really, thinking top tips and things we would like to share with pharmacy teams. We are wondering whether some pharmacies are closing down CPCS referrals when actually they could be claiming for them and missing out on income. Now, there's a way you can check, and you can actually do an audit yourself on your activity by reviewing it on farm outcomes. And we were discussing this with another LPC, and Greater Manchester told us they found one pharmacy that had incorrectly closed nearly £500 worth of CPCS referrals in a week. That's a lot of money. You can see we've put the table onto the slide for you. So we know that the referral rate, we have about 17% of those are dropped. Now, there will be times when actually them being dropped and no claim being made and being closed is appropriate. So we're not saying that that'll get to zero, because that's when you can't contact a patient. But I'm going to share some examples with you now around things where we wonder whether a claim may have been made. Before I do that, we've put a link into there of a useful PSNC document which talks about when it's complete, to make sure you are claiming for every CPCS where you are able to do so under the service specification. Can I have the next slide, please, Alison? So here's some of the real examples of the closed referrals we saw in December. There is a longer list than this, but we just picked a few out. So the decision as to whether to close a referral and how to record it is absolutely up to the pharmacist that undertakes that consultation. So we don't know the full details. We don't know exactly the conversation that happened with patients. So we are guessing a little bit from this data. But if I look at some of the things here, so for example, a patient doesn't want to come to the pharmacist to see the knee, well, that's their decision. But then there's also been dry patch is eczema, a steroid cream will help a patient prescribed. Well, there's also been a consultation about eczema and some advice given about the treatment and management of that eczema. So, could that have been claimed? Possibly, it could have been. Patients too young to be treated in the pharmacy. Baby just 17 days old with severe eye infection. Now, yes, we can't provide medication, but there's about actually what advice could have been given. So if it's, it's about that triage. The triage is actually now as a clinician, it's only a very young child, it's a severe eye infection, it should be seen by the doctor. So make a referral, put the CPCS claim in and get the money for the work you've undertaken. A couple in there which I don't think possibly could be claimed: failed to attend following contact with the pharmacy. So it sounds like they arranged for the person to come down, but they didn't. Not picking up phone to follow up referral. That's absolutely appropriate there, close. There's obviously not been that clinical assessment and the closure of that for that patient. But yeah, just to highlight that we do see quite a lot. We do wonder whether somebody may have been able to make a claim rather than closing that referral. So something to think about. So we thought it might be quite helpful if we spoke to a pharmacy who's been doing CPCS for quite a while and has quite recently started working with the local GPs to get the GP CPCS service up in their area. So next slide, please. I would like to introduce Chris to you also. Chris Bland's one of our Community Pharmacy West Yorkshire committee members. He also runs a very busy pharmacy in Leeds. So welcome, Chris.
Good evening, Ruth. Hi, everybody. I won't put my video on because it seems to knock my connectivity, so you either can see me or hear me, and most people who actually see me would prefer just to hear me. So,
I'm not making a comment about that, Chris, but I would much rather hear your responses because I think that's what people are going to find helpful rather than you having to try and do it by mine. So we've got a few questions for you, Chris. So just start us off. CPCS is an advanced service. Obviously, it's optional. So we know most pharmacies do provide it, but people don't have to. So it'd be interesting to know, why are you providing the CPCS service?
I think for us providing it was, we got signed up to provide CPCS from our head office, and when it was started it was just a 111, and it seemed quite nice and simple and straightforward, a few phone calls on a weekend. When the GP element came on board though, because we were signed up, like it's already been alluded to, we was in for it all. So I thought, well, if we're in for the full bang on this, we might as well do it and make a good go of it. And like you said, we're getting paid. The other element for it is we're doing a lot of this anyway. Patients are coming in, they're being referred from the pharmacy, especially with COVID, when patients can't even get through to the doctor. Everyone was turning up into pharmacy. So this just seemed, why can't we just get the referral from the practice? Then at least there's a record of what's gone on. There's the patient journey that is there, but also we get paid some pennies for it as well. So we had no choice but to do it because we were committed to the service, but also we were doing it for free. So in a nutshell, that's why we wanted to do it. Also, though, we think that there are lots of services out there. There is the DMS, NMS, flu, COVID vaccine if you're doing those. So it's just another service that get people into the pharmacy, show that we are good, we're a clinician, we're there, and the people can get help from us. So that was the real reasons why we set up and wanted to get it done and get an extra income stream in.
Yeah, that's really helpful to hear about the fact you were getting as unofficial referrals anyway, Chris, and so you may as well get paid for them. I think that's a really valid point.
I think the other thing as well is to remember is it's actually quite nice. You actually forget that you've done a degree for all these years. Some of us 3 years if we're very old, some of us a lot a longer one. But how much actually time do we spend talking and actually doing some clinical assessments? And when you've actually been able to sort a patient's problem out, it makes it feel a lot better, and then you go back to checking your next 200 items of prescriptions. But for those little bits of difference, it's quite good.
Yeah, that's great. Thank you, Chris. So we've talked quite a bit about communication between general practice and community pharmacy, and how important that is. How did you go about that in your area to try and kind of build those relationships and get that to work for you?
So I'm quite lucky. I am the PCN community pharmacy lead for my area, but I don't really think that makes that much a difference. The key things is working with the GP service, also working with the PCN pharmacist, but also speaking to the pharmacies around in the locality. What we wanted to do was not fight and scrap for things between us as a group of community pharmacies. It was, how do we work together? It's helped with stock shortages and things like that. But on this one is, I spoke to all the pharmacists and said, look, we need to do this. So do you want me to contact the surgeries? And we set something up. So I had a meeting with the clinical director for the PCN. We arranged then with the PCN pharmacists that we went in and did the training. So I went into 2 of the practices and did the training on the reception staff. My rationale was that is, yes, it's busy, it's hard work, and it was a cost commitment on my company, but I'd much rather a community pharmacist go and train the reception staff on how we want it done than let the PCN pharmacist, who's probably maybe never even stepped foot in the community pharmacy. So that was the key part. So getting all community pharmacists on board and kept them up to date with what was going on. And the other thing then was explaining how they were going to get the referrals. So we were using Farm Refer, so it went on to Farm Outcomes. And the most crucial bit though then is, how do we get the referrals back to the surgery? And we managed to agree a backdoor phone number. So like Ruth alluded to earlier on, we don't want to join the queue of 500 people in front of us. So we don't have time for that. That's the reality of it. If we've got the backdoor number, then we can just ring in and just speak to the surgery. We do follow it up by doing it on the Farm Outcomes in the feedback box at the bottom. That's really crucial because that's what the surgery sees when they get the message back. So we do write in there, referred back for a GP appointment. And we do follow it up with a telephone call to actually get that patient in. So there's a double whammy then of getting the message back. So that is the key though, and like I just said, the critical bit is, especially speaking to the doctors, is on the Farm Outcomes right at the bottom there's a feedback box. Really, that is the only thing that they see at the surgery. They'll get the tick box what the condition is and everything, but what you need to then put is, did you discuss the red flags? No red flags showing, or I've referred it back because of this red flag. I've told the patient this and told them to come back to me or go to you in X number of days if it's not improved. So again, it's that safety netting as well. But the surgery really want to see what's in that that note box. So when they get to speak to the patient, they can see on the patient's journal roll and that they've been referred to pharmacy. This is the outcome what pharmacy's done, and it completes it in. And what it just does then is that has built then the relationship then that we have with the doctors. They trust us now that we can do things like that. I know we mentioned about the services, but the hypertension service we've just started, and they're quite happy now to engage with us on that because we've built the trust already with the CPCS referrals.
That's really helpful, Chris, and it's great to hear that you kind of feel that trust has been built, that confidence built, and actually that's leading to other things. And it does sound like there was a bit of work and a bit of your time had to be invested in doing that, but it does sound like you're starting to kind of reap the benefits from that. So that's really helpful. Obviously, we've talked about why doing exemplary service is really important, and we've talked about that, Alison and I, but also you've mentioned it. So you've kind of touched on it, but if somebody asked you in a couple of sentences, why does doing CPCS well matter?
I think in the nutshell is we are a qualified clinician, and I think we're overlooked a lot. The pandemic has shown that more people are using pharmacy than they ever have done before. So what they want to do is we need to build on that trust and those skills that we've got. And if a patient has been referred to the doctor to us, some of them have, and I'll be honest, they've not liked it. I don't want to speak to you, I want to speak to a doctor. So you go in and you say to them, okay, I can triage you now. Let's see what's wrong with it. And if I think you need to see a doctor, I might be able to get you in a bit quicker. And once you explain it to them, and it could be even sometimes, look, you didn't need to go and see the doctor. You've got everything you need at home. What you're doing fine is right. Just keep doing it for a bit longer. Those graphs showed earlier on, sometimes it is just purely advice. I think what it is why we do it matters is it improves our relationship to the patient so they can keep coming back to us, and then we can build on all the other services, what we've got already and what might come down the road if patients trust us. But also it builds our relationship with the doctors and general practice, so therefore they have trust in us. And again, it works in the two-way street. So doing it good improves your rapport with the GPs, but more importantly, it makes the patients trust you.
That's fantastic, Chris. And last question, really. Things are, well, really busy seems to be underplaying it, but they're really busy in community pharmacy at the moment. How do you and your team find the time to provide CPCS alongside everything else you're doing at the moment, Chris?
So both yourself and Alison's mentioned farm outcomes is crucial. That is where you get the notifications. The better way of looking at it is that's where your cash machine is coming in your pharmacy. The worst thing I found is we had patients coming in, speaking to counter assistants, speaking to the pharmacist. I love the chat with them and everything. And then you go 10 minutes later and find there's a referral for that person who's just gone out of the door. So the key thing we do is we check farm outcomes many times in the day, purely for DMSs, to input needle exchange or to input methadone claims. We do all those in lifetimes rather than building them up. So we've always got reasons to go on to farm outcomes. If there is any GP referrals, we let the counter staff know the initials and the condition. So therefore, if someone comes with an earache condition or conjunctivitis, we just ask the staff, can you just say your name? Have you had a referral from the doctor? And if they have, therefore, it triggers on the pharmacist again. Because remember, some of those dropped off ones, it could be you have actually served them already in your pharmacy, but you didn't realise that that was a referral, because although they're told to say I've been referred, they're not always referred. So get your counter staff on board with it. And that is a key thing. You are doing this anyway. This person will be coming in. So you need to make time to make it happen.
Thanks, Chris. That's been incredibly helpful. Thank you very much for taking your time to share some of your insight and some of your kind of top tips. So yeah, that's been brilliant. Thank you. Can I have the next slide, please, Alison? So Chris mentioned a little bit about red flagging and clinical handback. Just to kind of talk a little bit about that, really. So we've used this stat all the way through. On average, 1 in 10 patients will need to be referred back. We know that varies quite a lot between different pharmacies and different general practices. There's lots of different reasons for that. Again, it's not a save as failure. Do follow that agreed referral route. And think of the way you make your handover. So this is really around, as Chris says, you know, as pharmacists who have to deliver the community pharmacist consultation service, we need to demonstrate that we are clinicians to others in the NHS who sometimes have forgotten that we're clinicians. We need to make sure that our handovers are evidence-based and that we communicate really clearly. Now I'm going to go through in the next slide a process called the SBAR process about communication. It's an evidence-based way of making referrals. So I've had a chat pop up and I can't see my slides anymore. There we go. And as I outlined, you know, you are responsible for managing that patient, making sure there's a robust clinical handover and taking ownership for that patient's care. So next slide, please, Alison. So the SBAR. So SBAR stands for situation, background, assessment and recommendation. I said before, it's evidence-based and it's been proven to be a really good way of making, transferring patient care between sets of clinicians. We have a little bit about SBAR on our website. Actually, we linked it to having conversations with GP practices around out of stock, so you're really clear on what's out of stock, but what you'd like them to do about it. But it can be used for any kind of handover. So I'm going to go through a couple of examples. So can I have the next slide, please, Alison? So thinking about clinical handovers, I've got a kind of two ways of approaching it here. I'm very good at right and left. On the left-hand side, we've got these are things we've had fed back to us from GPs. Patient has earache, not eligible for CPCS. Earache, needs antibiotics. Earaches, not able to undertake ear exam. They're all reasons that patients just been bounced back to the practice. And we know from the work we do with GPs that when they see a referral like this, they feel it's not clinical. They, have the question, what's caused this earache? Is it an infection? Could it just be earwax? Doesn't the pharmacist know that a lot of earache is viral and just gets better on its own? Don't they know how to give patients advice as to how to manage ear pain? So it leaves them with lots of questions and feeling that that person hasn't had an assessment, which may well not be the case, but that is how it's perceived. If we think about using the SBAR method for making a referral back, that starts with a clear statement about what you want. So the situation is an appointment needed for patient assessment. There's a 7-year-old patient presented with earache of duration for 3 days. Earache continues despite analgesia. So that's highlighting one of the red flag reasons where we should be referring back into the GP practice. Another example being appointment needed for assessment. Again, being really clear what you're asking for, what you expect them to do, so that's clear to them from the outset. Patient presenting with earache, very high temperature with discharge from an ear. And if you have, got any way of taking somebody's temperature and it's, for example, over 38 degrees Celsius, it's really helpful you actually put that in. We're not obliged to do clinical assessments of things like using an otoscope or taking somebody's temperature. But if you do have that ability and you do have done that, it's really helpful to include it. And we know from feedback, when GPs get referral backs like this, they feel that they've got the information they needed, they can understand why you've then referred it on, and they've got the confidence you've done all you can, but you then need their support from the practice point of view. So I just wanted to share those. So that it's the SBAR mechanism, a quite helpful way of doing it, because it doesn't mean it's a lot longer, but it just means you give a good clinical handover. Next slide, please, Alison. Oh, it's over to you actually, Alison.
Excellent, thank you, Ruth. So I just want to touch a little bit now on CPD and revalidation. And obviously the majority of this will be aimed at the pharmacist, because it's the pharmacist that's providing the lion's share of the service. So you may already be aware that the RPS are currently offering free CPCS workshops, and which supports effective patient-facing consultations. And we've had, or rather the RPS have had some really good feedback on these sessions. The training is delivered via a combination of online pre-learning and interactive online workshops, a little bit like CPWY are doing as well, and are facilitated by very experienced individuals, which include GPs and advanced practitioner trainers. The workshops are designed to support pharmacists in managing CPCS referrals and provide an excellent opportunity to be able to practice the skills required to deliver the service. Feedback from people who have attended the sessions already has been extremely positive, and if you haven't yet done it, we recommend that you at least have a look. And the sessions are available at all times of the day, including on a Sunday. Not that you might want to give up your Sunday, but it might just help you deliver that exemplar service that we've been talking about throughout the session. And we've put the link on there where you can tell a lie, we haven't, but the link, if you go onto the RPS website, it's pretty much the first thing that comes up on their webpage at the moment. And then, as you'll probably know from previous meetings, we have teamed up with Virtual Outcomes, and they are currently providing some free CPCS training packages, and this is training that incorporates the whole team. So a little bit like Chris was saying about, talking to your counter staff and letting them know that the initials and the likely presentation of people who have been referred from the GP practice. And CPPE have a range of training resources as well. And when I had a quick look this afternoon, some of those actually are directly linked to the RPS training as well. So they've obviously been having conversations between them to make sure that their training is all streamlined and linking up with each other. So we're nearly there now. So I just want to talk to you a little bit about what's coming in the very near future. So you should all be aware that the NHS England paying for the pharma outcomes licence for CPCS is coming to an end, and we're moving to a new model from the 1st of April 2022. Broadly speaking, it's being called Provider Pays. You have a choice of which system you would like to use, and you can stick with pharma outcomes if you wish to. But even if you are sticking with pharma outcomes, you do need to make sure that you fill in all the appropriate forms no later than some point in February. because if you don't do that, it could impact on the referrals and the service continuity that you have. And there's a link there on the slides that you can go to if you haven't already accessed that, to understand what's available and what you need to do to make sure that that happens. And that certainly after the end of March of this year, you will be required to procure your own IT system to receive your referrals on. So it's now over to you. If you've got any questions, feel free to ask them. You can either pop them in the chat bar. I can see there's probably a few there already, or if you want to speak to us, then if you can put your electronic hand up and we can work through those. I'm going to stop sharing the slides now, and then we can see who wants to ask questions. Thank you. So shall we start with the ones that are in the chat bar, Ruth?
Yeah, that'd be great. Are we doing it in reverse order, or?
Yeah, I'm just looking to see where they start.
Yeah, I think most of them are just comments, actually. So I think the first question we have is, can you by any chance show us how we process a GP CPCS? So from receiving an email to transferring it onto Farm Outcomes to get a payment. I don't understand this. I've done a CPCS through 111, but it doesn't make sense to me. So is there a resource that we've got that can demonstrate how to do that? So as I understand it, Samaya, that you should get your referral through normally through Farm Outcomes, and you complete it by just following the Farm Outcomes prompts and putting the information you need in there. There may be a video to demonstrate it. I'm going to have a quick look on the website now. Has anybody else got any other questions while we quickly have a look at the website to put a link on? Oh, okay. So referrals may be made by NHS Mail. It is for most, is the backup. So it shouldn't happen very often, but it might happen. So if that happens, you log on to Farm Outcomes, and opposed to actually picking the referral up, you can then just start putting the patient details in. So you still use Farm Outcomes. It's just that you won't have had the referral to you that way. You can then just actually start manually inputting that data. So you still use Farm Outcomes at the moment.
Yeah, you do. It's just to add that there's actually a manual entry template on Farm Outcomes. So if you receive a referral from NHS Net, you use the manual entry template on Farm Outcomes, and it's clearly labelled as for NHS Net referrals.
Thank you, Lisa. Khalil's got a question. If a patient has gone to college, spoke to his mum and said he will come to see you in 4 days later to have a look in his ear, do I complete the day I get the referral, or when I see him 4 days later? I'm not, I hope this makes sense. I'm not entirely sure that makes sense, but we should be, we need to see people in a timely manner. You might want to consider doing a telephone referral, but if it's difficult, if you want to have a look in the ear, I think if you do it 4 days later, it does look like you haven't responded in time. So what I suggest you possibly do is in the notes make it very clear that you did contact the person, but then they took 4 days to come back in. So that actually somebody is an audit trail as to why there was that delay. That's certainly my recommendations. Anything that Alison or Lisa would like to add to that? No.
Nothing from me, thank you.
Any other questions? The other thing I'd be quite interested to know is, who's seen a GP CPCS referral? We know Chris obviously has. If you have, be just good to put a yes in the box just to get a sense. Also, Khalil's getting them, or we're assuming it's a GP CPCS rather than a 111 referral in. Oh, Rochelle's had a test, so that's good. Yeah, hopefully that means that's a test with a hope that we'll get some more. Usma's had one, that's great. So actually, if you look at our website, cpwy.org, we have got a page on CPCS. The PSNC website is where you need to go for most of the information, but we put local stuff on our website, and what we do every month, we do update which practices we understand are going live. Now, we don't always get to find out till last minute, but we do try and keep that updated, so you might want to have a look on there, because you can then see the numbers, the increasing numbers of practices which are going live with CPCS, which is good to see. So there doesn't look to be any more questions, so there's no point in pulling things out. So I would like to take this opportunity to thank you all very much for coming. I hope you found it useful. You will be getting a follow-up email from us, including asking you to evaluate tonight's event. So it'd be good to hear from you about that. I would also like to say thank you to the team, to Alison and Lisa in particular for producing the slides, pulling it all together, and supporting the event, and also to you, Phil, for helping support the event as well. And I know you work with the PCN leads if they want to talk to you about CPCS and how they can support in their area. I'd like to thank Chris again for his really helpful input. It was really good to get that insight from somebody doing it on the ground. And it just leaves me, I think, to say, have a good evening, everybody. Do look after yourselves. This is recording, so if you do want to watch it again, give it about a week and it'll be on the website. So if you do want to watch it again or want to share it with any colleagues, please do so. Take care and do look after yourselves. Cheerio.